I think nowadays we should ask ourselves whether or not myeloma can become a curable disease. And to consider a disease as potentially curable, I think that at least 50% of the patients should be disease-free for at least 10 years. How far are we from there? 2 years ago, at that meeting, the Spanish and the Italian group presented very important data based on two parallel studies conducted in 2005, therefore, with a minimum follow-up of 10 years. These patients were treated with VTD, Velcade thalidomide dexamethasone, plus autologous transplant, plus maintenance with a sort of thalidomide maintenance. And in both of them, it was found that approximately 1/3 of the patients remain disease-free, progression-free survival at 10 years. Therefore, with the old regimes, we can say that this figure is very important because we can build now on top of this with the new agents, with the new monoclonal antibodies, and probably we can increase the cure rate close to around 50% of the patients. Or if we don't want to call cure, to have disease-free at 10 years in 50% of the patients with a standard risk. The problem is the high risk, and we are going to discuss also today. I want to go through this idea of curing using a roadmap of 5 potential important points. First of all, to know more about the biology of the disease, the biology of the resistant cells. And our group has focused on 2 groups of cells that we consider that may represent the Achilles heel. And one is the circulating plasma cells, because they are responsible for the dissemination. And the other group is the residual cells after an optimized treatment, because they are responsible for the resistance and for the future relapse. We have performed transcriptional profile analysis at single cell level on the circulating plasma cell, compared per samples with bone marrow plasma cells. And what we have found is that only a minority of genes, there were 56 genes, are significantly deregulated in the circulating. These are the genes that we should target. And something similar apply to the residual cells in per samples of patients treated with VRD. We have analyzed the cells at diagnosis and the residual cells, and we have found that only 700 genes were deregulated. And these genes, interestingly enough, are different in the standard risk from the high risk. In the high risk, the cytogenetic abnormality present at the beginning probably predispose the cell already to be resistant, while in the standard, the cell tries to adapt. We'll take a lot of time just to discuss about this, but I think this is the way to understand how should we work if we want to cure myeloma. The second point for curing, from a point of view important, is to have good method, sensitive method, to measure the efficacy of the treatment. And this should be applied with the goal of eradication of all tumor cells. And for this, we cannot use the conventional immunoprofiling based on proteins. We must use more sensitive techniques based on next generation sequencing and next generation flow, because they have demonstrated that they have the capacity to identify one tumor cell among 1 million normal cells. And it has been clearly shown by several groups over the world that the lowest the residual tumor load, the longer the survival, both in terms of progression-free survival and overall survival. Then these two elements, to know more the biology and to use good methods to identify the quality of the response, the depth of response, are critically important. And this should be expanded not only to measure, to evaluate the residual disease inside the bone marrow, also outside the bone marrow. And nowadays we have also evidence that the patients that achieve a PET negative enjoy a significantly longer survival. Therefore, I think these type of elements should be included in the myeloma evaluation in order to improve and to guide with a more precise tools the treatment decisions. And now let me move into the treatment. And this is my third point for curing: early detection, early intervention. In the past, we decided that smoldering myeloma should not be treated. Nowadays, we have accepted that the ultra high risk smoldering myeloma should be treated. And in fact, nowadays they are classified as active myeloma, patients with more than 60% plasma cell in the bone marrow, with a free light chain ratio of more than 100, and with the presence of more than one focal lesion. But we have another group of patients that are not ultra high risk, are standard high risk, in which the risk of progression to active myeloma is 50% in 2 years. And both the Spanish group, now many years ago, in 2013, 7 years ago, and more recently, the American group led the study by Segerlonial, have reported that if you use lenalidomide dex or only lenalidomide, you can significantly delay the time to progression. And in the Spanish study, we also saw it, that this was associated with an overall survival benefit. At the next IHA meeting, Dr. Mateos will present the long-term follow-up of the Spanish CureDex study. In this long-term follow-up, more than 10 years follow-up in the smoldering setting, we are going to show that the PFS in the control group for this high-risk smoldering is 2 years, the expected. What is in the patients that were treated in the treatment intervention arm? 9 years. In 7 years different. And I think this speaks by itself. And also this was associated with a clear significant benefit in the overall survival. Now the question for the smoldering patients is, should we delay the progression? Probably this should be the goal in the elderly patients, but in the young patients, why not to look for cure? And again, the Spanish group has already presented data at the last ASH meeting, as going to be presented again, about the strategy of curing patients with smoldering multiple myeloma, high-risk smoldering myeloma, by using a similar treatment approach to the one that we use in the conventional active myeloma. And in this case, we use KRD induction, 6 cycles, followed by a transplant, followed by consolidation 2 cycles, and maintenance for 1 year. And the goal is to have MRD negativity maintained, sustained at 5 years. The follow-up is still short, but I can say that in the 71 patients that has already passed the 1 year maintenance, the MRD negative rate is 62%. In other words, I think we are in the right way, and probably this early intervention could be associated with an increase in the cure rate of myeloma patients. Now, let me focus on the patients that are the conventional myeloma patients, those that require treatment. And we can separate the standard from the high risk. And if we talk about the standard patients, I want for the audience to say that a gentle approach probably is not the best option for standard risk patients. The standard risk patients should be the one that should be first treated with the best possible treatment if the goal is to cure this patient. And let me think about acute lymphoblastic leukemia. In the childhood acute lymphoblastic leukemia, were the common ALL the one that were first cured. And we pay probably some taxes for that toxicity. But we discovered the way to cure. The problem was the TALL or other subgroup that were more difficult. But all the efforts first concentrate in the standard risk. And I think for the myeloma, again, I want to emphasize that the best treatment should be used. And I have talked about minimal residual disease before. And if you have a treatment that is associated with 3-4 more times chances, 3-4 more chances to achieve an MRD negative status, this is the treatment that you should use for your standard risk patients.